How do you do you remember how to do the presenter view thing?
Just go ahead and start the presentation. It'll auto-populate.
Oh, okay, right here. Ah, sick.
Yeah, whenever you extend a screen, it'll always make the primary screen the presenter mode and the secondary one the presentation.
Gotcha. Is this thing recording?
What you looking for?
Trying to make sure this is actually recording. Oh yeah, it is.
Okay. Okay. Yeah, and they have the clicker that they can use.
Okay.
So is that really it?
That's it, man. Cool. Easy peasy this time.
There's Kanan. Hi, Kanan.
What's up?
It's right. How you doing?
There's
How you doing? Good.
You know,
Live over here now?
first speaker that's emailed ahead
Oh,
with
you
the science
said
data.
you live over here now?
I do, yeah. To get it all set up
Right.
early. And Kanan said, well, she already. Do you have the water?
Water.
I thought it would be up here.
Hold on. I'll go grab it real quick. I'm just up on the floor.
Oh.
Grab it.
Okay.
Oh, thank you.
Do you
Okay,
mind if we record your seminar today, by the way?
don't mind at all.
Okay, I went ahead and started it, so I completely forgot that we did that.
Oh, right, okay.
So let me, okay, so mouse,
Oh, there's a clicker on the thing. You can just use the clicker to go from slide to slide. It should be working already.
this,
Yeah, it should be a left and a right arrow.
Yep.
And then you can just use that to go from slides.
okay, and then use this to point, yeah.
Yeah.
So I don't actually have to stand back here unless I want to look at my notes.
Unless you want to. And do you have notes?
I might,
You might, oh, okay. If you don't like this, we can make it. a
yeah,
bit-
sometimes I do,
Perfect.
that's great.
We have Kanan for our head and neck support group. So,
No,
oh man.
so
He's been great.
Yeah,
Kanan,
no, he's good.
he used to work for us full time over in, I don't know if he told you, but like, so Smita's husband stole him from us. So her husband runs the stem cell transplant program here. And so when Kana was looking for a promotion, there was one step up available in stem cell. And so he got hired there. And he was stolen away, but then Robbie decided to share him back for the purpose of our seminars for now. Because we haven't replaced his position yet.
Well, he was great.
Yeah,
I
yeah,
mean,
he's great.
He made, I mean, I don't know, the UAV supplier was trying to get all this information from me. I was like, I don't even know what they want me to click on. He goes, just send it to me, let me see what it looks like. And you know what, I think we do have plenty of time.
Yeah.
10 minutes, so I
Yeah.
think I will run to that brush.
Sure, yeah, I'll show you. I'll point you in that direction, because it's.
Brushing off that. Let's see. There's some- I have a. What the name's virus? One that's the time.
Steady going. Now we have more. It is a lot. I think so, it's not so bright, that's fine, I think.
Yeah, I can do that.
Yeah, Dr. Bachi was, she was actually in this week with our DLC clinic, where this child is where she is. A student about the findings.
How about it?
Oh, yeah, I think that's good. We still-
The back good, or you want the-
Let's do this one.
Back
I
on.
think the back side.
Front side.
Just that front and side. Yeah. We have a bunch of your speakers. How are you? Well, how are you? Good. Thank you.
I'm saying.
I don't know, my hands are very much.
Yeah.
Yeah, this was sort of a, fun talk. Talk a lot about fertility preservation and about survivorship, and not usually in the same.
Yeah.
So sort of trying, I think about it as a spectrum. Was fun. It's sort of, it's fun to be challenged.
Yeah, yeah.
So St. Jude had a workshop think tank about fertility. They're trying to develop a fertility program in their communities. And I gave I talked about reproductive health and survivorship. I was surprised how much interest that, and I think I sort of realized maybe realize that 10% of people go to
clinics that have
survival program. Then how many people really don't revisit their risk of reproductive health?
Oh, yes.
Which is so important. Yes, I would say patients don't care, their heart's beating, their lungs are better care about when they're. And yeah, so that's really. And I mean, and plus a lot of people, if they got the information diagnosis, they've been very young, they've been 3, 4, 5. So the patients themselves.
Yeah, and we get a lot in clinic where they say no one ever told me this. But in fact, probably someone did. It's even in the consents that they signed and so forth, but it's just, they're just so overwhelmed. When they're diagnosed, they don't have it's matter.
What they did hear.
Yeah, exactly.
You know,
If you don't hear it,
if they didn't hear it and they can't report it back, then we might as well think it didn't happen.
Exactly. And especially of course, if there was no attempt to preserve the stage, it was not top of mind.
You know, if they did preserve fertility, then hopefully they're
Hopefully they
paying.
remember. Or-
Well, they'll remember because they're saying
Yeah.
the specimen frozen.
Yeah.
But, yeah, so.
And I should warn you that this is actually a really busy street that connects with ER, and so very often there's loud ambulances going by all the time. So don't, yeah, it just happens.
Comic relief, or,
It's a call.
yeah, falls, it's of water.
Yeah, I also gonna get to tell you that I can't come to dinner tonight. The AFON, Association of Pediatric Endocrinology Nurses Conference is starting this evening. And I'm flying out to Salt Lake City this afternoon. So it's going from now till Friday, so.
Salt Lake City?
Yeah. So I'm heading out. So I'm sorry. I'm gonna miss it. Yeah. I know. Yeah, there's San Francisco. But we really wanted to do that, I hope that like this, what you were hoping for as far as the people.
The big one is not really enjoyed talking to. Julie,
Yeah, she's been instrumental.
Like it's
in getting things going.
great, like it's great.
Good energy. So Julie came with you guys from.
Yeah, she came a little after we did, but from City of Hope. She waited till the kids were like down with their school.
Oh, sure.
Before she moved out. Oh my gosh, when the kids were like kindergarten, when she came in the high school.
That happens. I was looking at all the things that were written on the window and where her kids were.
Yeah.
Love it.
Yeah.
I should do that more often.
Yeah. Yeah, it's pretty great. It's kind of an evolution. Them visiting. She used to have them in there all the time. Yeah, when they
You
were
could
little,
see, yeah.
when they were little, and they'd be on the floor doing stuff. But now, hardly ever see them. Yeah. They're all doing their activities.
She works.
People give her questions. Yeah. I know, if you give her pictures, she will display every day.
Oh, I don't know if I have to stay back there to be able to be picked up by the mic.
Let's see, I think there's a,
She was asking like about maybe like flip on mic or something.
No, I don't want to put on.
pretty much then, yeah.
A lot of speakers still at the front.
But will it be picked up on the recording? No.
It won't.
I'll take a hand podium.
Yeah, I think you have to.
Good morning, everybody. Can you all hear me at the back? Great. Thank you. Thank you for coming for today's monthly seminar series. We are absolutely delighted to have my dear friend of like 7 decades.
7, yeah.
Sure. Lillian Meacham, Dr. Lillian Meacham. Dr. Meacham is a professor of pediatrics at Emory University. She's also the holder of the Kathleen V. Amos Children's Chair for Cancer Survivorship. And she directs the Fertility Preservation and Reproductive Health Program at Emory. From birth onwards, Dr. Meacham has been at Emory, right?
True.
Right. So Emory is where she went to med school, residency, pediatric endocrinology. And Emory has been extremely fortunate to have her. In fact, last year, they awarded her with an award for clinical distinction. And that was fantastic. Lillian, you've given talks, which if I counted them, we could go to the moon and come back. So how we know Lillian is because she's a font of knowledge as it relates to pediatric endocrinology, as that relates to oncology. And if we need anything, we go to Lillian, whether it is in the adult endocrinology world or the pediatric endocrinology world. And her word is the word of authority. Lillian, how shall I put it? I think you've really stood by what you say and provided evidence for it. And truly, I think you are the authority on pediatric oncoendocrinology. I will keep sending you manuscripts to review, so do not refuse them. I said that in front of everybody. So here we are, ready to listen to you. Okay?
Thank you, Dr. Bhatia. I'm so honored. I'm really honored to be here. I have admired Dr. Bhatia and Dr. Landier's work for years, and I'm actually in awe of all that they've done and a little nervous to be here to present to them. So I have practiced, I've like worked on these slides. I want them to serve you all today. So, and thank you very much, Smita. That's very, very kind. And certainly amazing work is being done here. So I am a pediatric endocrinologist, so don't ask me hard cancer questions. But I am embedded within the Aflac Cancer and Blood Disorder Center. And in 2001, started their cancer survivorship program. And then in 2015, started the Fertility Preservation and Reproductive Health program. I have no disclosures. So this is a little bit different talk. I was telling Wendy ahead of time, I talk a lot about fertility preservation and that end of the cancer spectrum, and I talk a lot about survivorship, but I've never really actually sort of thought about the continuity. How do you do this across the whole spectrum of time for these patients? And it's interesting because Wendy told me an amazing fact, a disturbing fact, that perhaps only 10% of patients really get true what we want them to get, survivor care. So 10, 20%, 20%. So, you know, that even puts more responsibility on us to be sure that patients have the right information about their reproductive health. And we may have to do it at different time points if we're going to be sure that they're going to have the knowledge that they need to make decisions in life. So I thought we'd start by talking about how do we identify gonadotoxic exposures, because that's where we start. If we're going to talk about reproductive late effects, not all treatments, of course, are going to damage the ovary or the testis. So we need to be focused in the agent. So I'm going to talk a little bit about how we do that. Once we've done that and we've quantitated their exposure, we have to put it in buckets of risk for them. Are they low risk? Are they significant risk? Or are they high risk? Because they'll make their decisions and their reproductive options will vary with what bucket they're in. So how do we do that? And then how do we implement that? Okay, so we can have all that knowledge, but how do we actually deliver that clinically? And I want to talk about it, diagnosis, what fertility consults look like and what fertility preservation looks like. And then in survivorship, how do we educate our patients and how do we help them with fertility status assessment? So I rely on what I use and what I try to align with is the Children's Oncology Group long-term follow-up guidelines for survivors of pediatric, adolescent, and young adult cancer, which was started by your two leaders here, Dr. Bhatia and Dr. Landier. They did a mammoth amount of work to generate these guidelines and then to revise them. And the most recent version was published last fall, and it's version 6. So if you went to the website, this is what the page looks like. And then this is what a specific page will look like. And I want to walk you through this. So can you see? Oh, there we go. Okay, so this, you start with the section number because the section number becomes important. So the section number will then, this is section 13, which aligns with telling you what that we're looking at classic alkylating agents, heavy metals, and non-classic alkylators. So if a patient was to be treated with these treatments, they are at risk for impaired spermatogenesis, and that is the only late effect that's addressed in this section. The next are, this is guidelines for people that are doing long-term follow-up. This will actually tell you what you need to do in terms of the history, the physical, and if indicated, laboratory test or radiology studies. So this is like the workbook. This is what, if you want to see a survivor, this will walk you through it. This section on the far right is a little bit of a lot. It's like a mishmash of things, but it includes a health link, which is a patient teaching handout. Very helpful to inform a patient if they want something to read about impaired spermatogenesis, information about resources, how to counsel patients, and when to refer them. For those of us that want to know, well, how strong is the evidence that alkylators are associated with impaired spermatogenesis? This tells you. So this little box will tell you that the classic alkylator score is 1, which means strong evidence, concordance in the working group or the advisors. 2A would be less strong, still concordance. 2B would be less strong evidence, and the working group is like not totally in agreement, maybe. And I think that's important to know. Lastly, additional modifying factors you might want to consider as you talk to your patient who got alkylators about impaired spermatogenesis, and then the references on which this section was based. So this, if you will, is my guide to figuring out what patients I need to counsel about reproductive health risks. These are the different sections within the guideline that have to do with reproductive health. So it's going to tell you what these sections apply to chemotherapy for both males and females, for radiation for both males and females. So this is going to look at radiation to the gonad, the ovary or the testis, and radiation to the hypothalamus, which has to signal the gonad. Bone marrow transplant, and then different elements of surgery. So this is what you need to think about before you're going to go in to talk to your patient about their risk for infertility related to their cancer treatment. Okay, so then let's move to, okay, I know what agents I have to look out for. How am I going to counsel them about their level of risk? Let's see. Okay, so determining the level of risk, you're going to utilize your COG protocols. You're going to have to go through the protocol. So if I have a patient that, a solid tumor patient that's going to be treated on a given protocol, I'm going to go to that protocol and I'm going to look, did they get alkylators? Did they get heavy metals? Are they getting radiation? I'm going to look at the cumulative dose of intended chemotherapy and the anticipated radiation dose. So we're going to have to gather that information. And then once we have that, we can actually assign risk level. I will say that when I started in oncofertility, everyone defined this differently. If you were at Institute A, I might say the cut point for risk to be at high risk for infertility might be for females at 8 grams per meter squared. Now, if I went to institution B, they might say, oh, well, it depends on whether they're pubertal or prepubertal. You go to institution C and they'll say, no, we use 12. So what we tried to do in 2020 was the Pediatric Initiative Network of the Oncofertility Consortium brought together a working group of 26 clinicians and researchers. And oh yeah, the researchers used a different cut point altogether. So we came together, we reviewed the literature, and we came to consensus about how we would put people in different buckets. And we came up with this. And I know it's busy, and I'm going to walk you through it. Now, I'm going to say we realized from the start that this was just a beginning point. We knew this would be revised, but we needed somewhere to start. So what we did, and actually version 2 is currently underway, and Karen Burns from Cincinnati is leading that effort, along with Jen Levine and Kari Boujard from many of us know, and Allison Close and myself. So if you look, let's start with males, because males are maybe a little bit more straightforward. This is the alkylator exposure, and CED is cyclophosphamide equivalent dose. And that came from a paper published in 2014 by Dan Green that took all the alkylators and gave you a conversion, most of the alkylators, gave you a conversion factor where you could convert it to cyclophosphamide equivalents. Okay, so now we have an equivalent dose and we can put that into the grid. So for males, you can see we have alkylators, transplant, and all transplants, whether myeloablative or reduced intensity, are felt to place patients at a high level of risk. Can you all see that? Let me read it to you. This is minimally increased risk, significantly increased risk, and a high level of increased risk. And there's lots of debate about the terminology of these column titles. I'll be happy to talk about it offline if you'd like. And then we have heavy metals, radiation to the testis and hypothalamus, and surgery. I'm going to point out that males, in terms of gamete production, are very sensitive to chemotherapy and radiation. The CED that puts you at high risk for males is 4 grams per meter squared. For pubertal females, it's 8. For prepubertal females, it's 12. So the male testis is very sensitive to chemotherapy and radiation. Look at the radiation dose, 4 to be at high risk, whereas in females, pubertal's 10 and prepubertal's 15. So, and I'll come back to this later, but the male testis for gamete production is exquisitely sensitive. Okay, so we developed these as a starting point so we could have common language when we're talking about risk for gonadal dysfunction, infertility. And let me pause there for a minute, because what patients really want to know is, am I going to be infertile? Am I going to not be able to have children? And trust me, this is really important to them. You can tell them your heart's going to fail, your lungs are going to fail, and they'll be upset, but you tell them they can't have children and they're really upset. So it's parents and patients. I'm not saying it's right or wrong. It's just woven into many people that's really important. So I think that's an important consideration. The other thing is infertility as an outcome. It's very hard to measure. What is infertility? It's not being able to become pregnant or to initiate a pregnancy after a year of trying. Okay. That has to be self-reported, right? You can't, that patient has to report, I've tried for a year, I can't become pregnant. And then if you want to look at that, we're trying to collect that information on pediatric cancer survivors, hopefully not when they're still in our age, when they're getting care from us, but instead when they're young adults, and often they've moved away from our system, so it's very hard to track. And then if we want to look at their rates of infertility, well, we have to compare it. It's very hard to get that denominator, to get people who didn't get alkylators, but were treated and weren't able to become pregnant. So infertility as an outcome is very hard to measure. Well, you say, well, we can get fertility rates, we can get birth rates. Infertility is not 1 minus fertility. If your fertility rate is 60%, your infertility rate's not 40%. In that 40%, some people may not be trying. Some people may not want children. So you can't just make that assumption that the other 40% are infertile. So it's very hard to capture. So we use surrogates. Surrogates like premature ovarian insufficiency, diminished ovarian reserve, oligospermia on semen analysis. But the research in this area can be very challenging. Okay. All right, so we developed this risk stratification chart, and then we realized that not everywhere has a dedicated fertility person or a dedicated fertility team. This is a lot of work to go out, figure out the protocol, go through the roadmap, calculate the dose, and then go back to the chart. First, you got to look it up, find the chart, and be able to then go see the patient. So a group of us decided to go through, with COG's blessing, to go through the phase 3 protocols from 2000 to 2020, and we abstracted the gonatotoxic exposures. And we did this for leukemia, lymphoma, and then we put them into, because I pointed out earlier that it was different, the risk levels were different for males, pubertal females, and prepubertal females. And so then we went ahead and assigned the risk. So now oncologists can just pull these tables and at least they have the bucket that their patient falls into. And honestly, for males, I mean, you can see they're at high risk. Sperm bank, sperm bank, sperm bank. So, and then you can counsel females so that they can make appropriate decisions about what they want to do. So these charts were published for the leukemia and lymphoma. Well, I'll come back to that. Let me first start here. This is another depiction of the data. And what you'll see is these are the ALL protocols, the AML protocols, Hodgkin's and non-Hodgkin's. So I thought this was a nice visual to be able to see how the protocols fall. And again, it's for males, pubertal females and prepubertal females. Red is high risk. Sort of the orangey color is that middle significant risk. The yellow is minimally increased risk. Green is they were not getting a gonatotoxic exposure, so they shouldn't be at risk. And then the gray is unknown. So who wants to guess it? Let's see if anybody knows. Why do we have gray under Hodgkin's? This is a real trick question. Bonus question. Huh? Oh gosh, we have to put them in there too. These are it's actually dacarbazine. The carbazine doesn't have a conversion factor, but you're going along the same line with it. These will have to be updated with all the new targeted therapies. So, you know, and then AML. I mean, what's interesting about AML, no risk unless what? They go to transplant and then they're high risk. Okay. So, and that's hard for counseling, right? Okay, so we published the leukemia and lymphoma protocols in 2023. Earlier this year, we did the solid tumor protocols, and then this summer, the CNS protocols. So these are all in pediatric blood and cancer, and hopefully they're going to help people that want to do a good job with fertility counseling, but just really don't have the bandwidth to be able to go back and abstract all of this information. All right. So now we know what makes them at risk. We know how to stratify their risk. So how do we actually put this into clinical care? So, you know, we do fertility consults at the time of diagnosis, and this is a very overwhelming time for families. They've just learned that their kid has cancer. They've just learned the name of the cancer. They're trying to consent to protocols. And then in I walk wanting to talk about risk for infertility. It's really, I think you have to be very careful in how you think about what information you give families and how you give it to them, because it is so overwhelming. But I try to say, they've gotten such bad news. And I try to say, you know, I'm talking about preserving fertility for your kid's future. Like I'm already looking at when we're done with all this treatment. So I'm hoping that it comes across as a little bit of hope for them, that this is why we're addressing this now. So identify key concepts. Don't overwhelm them with information. Have a few key concepts you want to get across, including their level of risk for future infertility and the options for fertility preservation that are available to them. Don't forget contraception, okay? Because you're talking about infertility, in an adolescent's mind, that means, okay, cancer and my cancer treatment can be my birth control. I don't need to use, that's not a good idea. So be sure that you make a point to talk about contraception. This is actually the sheet we use, and it's got a lot of information on it. This is what we use when we do our fertility consult. So we have a team of 4 people. We have a part-time physician, me, a part-time nurse practitioner, and 2 nurse navigators. We're all about 0.3 FTE. We cover 2 hospitals that are 10 miles apart. But it's great. We have like a group email if anybody wants us. Aflacfertility@choa.org, and it hits all of our mailbox. We have a group text. So we're able to say, hey, who's at Scottish today? Can you go see the newly diagnosed boy with Hodgkin's? So you have to have a well-oiled machine. But this is our fertility consult tool. And I think maybe what might be overwhelming is this part where we actually put in what we've abstracted from the chart. And this is given to patients in terms of their gonadotoxic exposures. And I'm like, do the patient really need to know this? But this may be their only shot to really have it, especially if they don't come back to survivorship or they move. So they're going to get this piece of paper. And then I take this information and tell them how I'm using that to decide what level of risk they are. So I'll circle, well, you're going to get this amount of heavy metals, or you're going to get radiation, and then I'm going to indicate where their level of risk is. We go over all the fertility preservation options, and I tell them what is available to them. Because if they talk to Johnny, who had a totally different kind of cancer and was a totally different age, he may have had an option available to him that they're confused about. So we make a point to say what they can, what they have an option to pursue. Most important box. At the end of our discussion, we make sure that they understand, either by utilizing teach back or by just telling them what their level of risk is and what their options are. So this is what we use to do a fertility consult, and this is provided to the patient. So what are fertility preservation options? Well, tried and true in pubertal females is ovarian stimulation with oocyte harvest for egg freezing, and in some cases, embryo cryopreservation. For prepubertal girls, the only option is ovarian tissue cryopreservation. I'll talk more about this later, but it's removal of a whole ovary prior to high-risk therapy. This became non-experimental in 2019. It can also be offered to pubertal girls who want to preserve their fertility but don't want to go through the egg freezing. For boys, tried and true sperm banking. And for boys who can't produce a specimen, you can consider testicular sperm extraction. For prepubertal boys, only experimental options, and that is testicular tissue cryopreservation. In some cases, I suppose pubertal males might be able to utilize that. Sperm banking. So sperm banking can be offered to Tanner 3 pubertal males. I usually, because oncologists are adverse to doing Tanner staging. So I try to tell them this is probably going to be, I don't know, is that true here too? I mean, you'd think they're all afraid of pubic hair. I mean, so we usually say that's going to be about a 13-year-old boy. So if they're like 12 to 13, you can be assured they'll ask me to go in a Tanner stage. But anyway, so if they're about Tanner 3 and about 13, we think that they will be able to produce a specimen. And we have a mutual friend, James Klosky, and I love that he's a psychologist, and I love they teach me so much, but I'm going to share this pearl with you. So, if you aren't sure if this boy has ever like masturbated, then, how are you going to have this conversation? And he just makes it real easy. He said, just ask him, has anything ever come out of your penis except for urine? Works great. I've given that to you. It works great. Patients aren't embarrassed by it and they can respond. Okay. So you want a sperm bank before cancer treatment? Yes, the ASCO guidelines actually say that, not after chemotherapy is started. It's about it's not about whether they can produce sperm. It's about the integrity of the sperm. This is going to usually be at a reproductive health clinic. There is a mail-in option, MAIL. It's expensive. It's about $500, but in places where they can't get to a fertility clinic, this is an option. The cost is usually in a fertility clinic. I don't know, correct me if I'm wrong, but this is about $130 to $300 in Atlanta. We actually have this paid by a foundation for all of our patients. You have to mention the annual freeze rate. The annual freeze rate can be $300 to $400. And that's a lot for some families. If they bank at Reproductive, Verna's purse, and they apply to that, will reduce the cost to $111 per year. Okay, that's sperm banking. While we're on males, let's switch over to testicular tissue cryopreservation. Remember, this is experimental. There have been no human births. There's been one primate birth, this little fella in the corner who's named Grady, and that was back in 2019. It's a testicular tissue biopsy, 0.25 centimeters cubed, top of a pencil eraser. That nobody uses pencils with erasers anymore, but that's what it would be, about that size. And should only be offered to patients that are at high risk for infertility, and only through an IRB protocol. And remember, this is the only thing we can offer to prepubertal patients. Ideally before treatment starts, but they will harvest after treatment if you've not reached a certain level of exposure. This is Kyle Orwig's study. He is at the University of Pittsburgh. Great guy. If the patient enrolls on his study, it's free up there, but they've got to transport themselves to Pittsburgh. If they end up paying for it, it's somewhere around $5,000, and you still have the annual freeze rate. What about girls? Okay, so this is egg harvest. And these pictures are to show that in order to do ovarian stimulation, you're doing injections once to twice a day. And most oncology, regular patients are maybe like, I don't know how I can do that, but oncology patients are sort of used to it. Of course, we're doing this before they're actually getting into their oncology treatment. But this can be a deal breaker. And what you're trying to do is every month there are follicles trying to mature, growing follicles. One will become fully mature and release an egg, right? I'm embarrassed. Okay, if I'm saying this wrong, you can tell me afterwards. But what you're trying to do with ovarian stimulation is get all those follicles to reach that maturation state so that they all now have a mature egg that's ready to be harvested. With sedation, with a transvaginal ultrasound, with a needle that extends from the tip of the ultrasound probe through the wall of the vagina into the ovary, into the follicle, they aspirate. There you go. You have an egg. This, of course, has to be done through reproductive medicine. It's expensive. It's going to be $10,000 to $20,000 per cycle. They have the freeze rate, they have the annual freeze cost. Also, I haven't mentioned, but there's cost associated with using this material in the future, which can be substantial. I would say most AYA, adolescent young adult females, cannot or do not utilize this option. For one thing, you have to delay cancer treatment for 2 to 3 weeks. Give it a week to figure out the financials and 2 weeks to actually do the stimulation. And they can't delay their treatment that long. The expense and the invasiveness of the procedure. So we do have some patients go for this, but not many. Okay, the last thing. Ovarian tissue cryopreservation. So this is actually the laparoscopic removal of one ovary. I would offer this currently only in high-risk patients. It's the only option for prepubertal girls, but maybe a good option for pubertal girls as well. Ideally before you start treatment, but if treatment escalates or there's a relapse, they will, you can sometimes do this while the patient is on chemotherapy. That idea, usually we want 6 months off chemo in somebody who relapses before we bank eggs or bank sperm. So ovarian tissue and testicular tissue, you can actually do it while you're on chemotherapy. Many sites are doing this. It's costly. If you do it with line placement, hopefully insurance will cover it variably, but it can be $5,000, $7,000 up to $10,000. And then you have your annual freeze rate. And then what happens in the future, you can transplant this tissue back into the patient. There have been plenty of pregnancies doing that, or they're working on in vitro maturation. I would say I'm still a little hesitant about this in pediatrics. And our friend Jen Levine says just because we can do it doesn't mean we should do it. There have been 2 births, in patients that have had their tissue harvested as a non-adult. One was in a girl who was pubertal but before menarche, and one was in a pubertal girl. Don't know that it means it doesn't work. I think some of that may reflect these girls are not old enough yet to want to try to use their tissue, but there's not a lot of evidence about success of this procedure in pediatrics. So this was our first OTC at CHOA, Children's Healthcare of Atlanta, and you can see the laparoscopic removal of the ovary. Look how little it is. And look, it's like less than 2 centimeters. Oophorectomy is usually done by pediatric adolescent gynecology or pediatric surgery. And there all kind of talk about how you minimally manipulate the ovary and what kind of media it should go in, et cetera, et cetera. So it's still also a developing field. All right. Let's switch gears. Okay, so we talked. All right, now we've gotten through diagnosis. We've done a fertility consult. We have given them their options. They've made their choice. So now what happens? So I think that communication about treatment-related reproductive health risk over the cancer care continuum. And I think that an important issue here is a transition of focus. So at diagnosis, you're talking to parents and you're talking to patients depending on the patient's age. Okay, so if it's a 15-year-old boy, you're obviously involving him in the conversation. But if it's a 3-year-old child, they aren't going to remember anything about this conversation. And if they don't come to survivorship, that could have been their one shot at the information. Off therapy, it may be mentioned. I don't think it necessarily is at our institution. Survivor care, they're usually, when they run the list of things you're at risk for, infertility will be in there, but not discussed at length. Not their level of risk, et cetera, or how we can assess for survivor care. Then at puberty, okay, this is our chance. And actually in our survivor program, myself and that nurse practitioner that does fertility preservation, we are both embedded in the survivor clinic, and we do endocrine care and reproductive health care in survivorship. So we see about 50 to 60% of all survivors that come to our clinic. But okay, here, see, it's becoming a solid line. We're starting to engage the patient more. And this is what I want to talk with you guys about. At 18, there's a hard stop. Every patient is offered information about their risk for male or female. We call it the male talk or the female talk, and that's how it is on the schedule. We offer them that discussion, have it again at 19, have it again at transition. I think you all will all agree that developmentally, a 13-year-old is very different than an 18-year-old in how they process information. And I would say an 18-year-old versus a 21-year-old are very different in how they hear it and how they interpret it and how they integrate it. Okay, so let's talk about it, puberty. So I'm trying to set the foundation. It's okay to talk about this here. I'm cool. I'm cool with talking about ovaries and testis and fertility and sperm and eggs. And I'm just trying to let them know we've got a plan. This is where we can talk about that. Of course, they'll have to have their pubertal status assessed. And I start to open that door by saying, you know, the ovary and the testis, they have two jobs. One's to make hormones and one's to make gametes. I don't say gametes, I say eggs or sperm. But they're like, oh, because I also think that I don't usually push the fertility envelope here or information about infertility. One, parents get totally freaked out if I do, but if they ask the question, I'm going to answer. Okay, so and our psychologist will say if they can formulate the question, they can handle the answer. So we introduce the concept of late effects. I reassure the parents by letting them know I have a surveillance plan for this and within survivorship, and that often relieves the parents that they don't have to figure out how they're going to tell their kid the information about risk for infertility. And again, be sure that they know they can ask those questions here. Okay, so we are going to, for males at puberty, we are going to see males who are at risk. I don't see individuals who are not at risk. Okay, so I'm really depending on my oncology colleagues to tell them you're not at risk. But growth. So we're going to, part of what we're going to assess is their rate of growth, height development, and their pubertal development, and they should be Tanner staged. And this is a Prader orchidometer, which will say that in childhood, testicular size is 1 to 3 cc's, early puberty 4 up to maybe 8 cc's, late puberty and adult. The important things to be able to differentiate is a 3 cc and the 4 cc testis. Okay, so again, you'd have to actually look to be able to do this. But if you are going to, I do want to tell you that when you get a lot of gonadotoxic treatment, it can be tricky to ascertain testicular size because the testes are going to be small. They might be 5 cc's, but the kid will have, but you'll be confused because they're these small testes, but they're 10 or 5 for genital development and pubic hair, and their testosterone level will be 380. Leydig cells. Leydig cells are super resilient. Okay, the Leydig cells make testosterone. So they're going to make testosterone. They're going to go through the physical changes, but the testes are small because the germ cells and the Sertoli cells have been lost. So that often confuses people. If you want to measure, testosterone can be low in patients that get a lot of treatment, like testicular radiation or very high dose alkylators. If you're going to screen for a testosterone, please get it first thing in the morning. The circadian rhythm is such that you will catch the highest testosterone at 8 or 9 a.m. How about in girls? Okay, so in girls, gamete and hormone, remember 2 jobs, make hormones, make eggs. They are more concordant. If you have hormone failure, you're likely to have egg failure as well, failure to produce eggs. However, I always get this, well, they're menstruating, so they must be okay. That's not necessarily true. And we've written a paper on that. They still could have diminished ovarian reserve. They could still have a marginal FSH. So that just because they're menstruating, even regularly, it doesn't mean they've gone unscathed through this process. Ask about menarche, ask about the quality of menses. Okay, so confession to the COG gods here, COG guideline gods. I don't follow the COG guidelines. The COG guidelines say in patients at risk, if they're not developing puberty, you can start screening them at 13 or 14. If I'm an endocrinologist, I'm embedded in clinic. If I think a girl's high risk, I'm going to start screening her at 11 because I don't want her to have an FSH of 30 and not treat her until she's 13 or 14. So I'm going to go ahead and institute hormonal therapy, hormone replacement. I get an FSH and estradiol. If the FSH is above 40 with irregular menses, that is POI, premature ovarian insufficiency, aka premature menopause, or ovarian failure. I do get AMH. I think AMH is the only way and the COG guidelines don't say that. So you consider doing this, but we more regularly do this because this is how you decide on whether this girl can have egg harvest after the completion of treatment. Okay, so let's talk a little bit about this. My favorite curve in the world, the Fatty-Gostin curve. The Fatty-Gostin curve tells you that all girls are born with 1 million eggs per ovary, and they lose them over time. When you hit this threshold of 1,000, this is your primordial follicle pool or your ovarian reserve. When it hits 1,000, menopause occurs, typically at age 50. In a girl who has had cancer treatment, she's lost a significant amount of her ovarian reserve, or may have. So now she has diminished ovarian reserve. She's going to have parallel loss, continued loss of her follicles, and she's going to have menopause in her late teens. This is the window of time I have to harvest eggs. How will I know whether she has DOR? By measuring an AMH, anti-mullerian hormone, which is made by growing, developing follicles, or a natural follicle count. And that is usually something that's done by REIs. You need a vaginal ultrasound. You can try to do abdominal, but you need a really good picture to make decisions based on this. And of course, you can't harvest eggs if the patient, or probably it won't work if the patient already has ovarian failure. Okay. Then I've been really troubled in that patients have very differing perceptions or understanding of their risk. Like if you ask different females or males that are 15, they have quite discrepant risk. And I thought about that. And maybe it's because endocrine follow-up can be quite variable. Females who have POI are going to see me every 6 months for 2 years and then annually. Lots of opportunities to talk about ovarian health. Females who are at risk for diminished ovarian reserve, they're probably going to see me regularly too, maybe annually if they want, so that we can monitor AMH. Females at low risk may not see me till they're 18. So all that time, they probably don't really know whether they're at risk or not, or they know based on their experience at Camp Sunshine, or, the camps where they hear what other patients have. Same thing with males, because remember, males aren't going to have low testosterone, so they really don't need to see endocrine until we have this hard stop at age 18. So you can see why perceptions, even in our adolescent patients, can be very different. So what are the perceptions of risk? So this was a paper from the Childhood Cancer Survivor Study that Jordan and I wrote, where we looked at 1,233 males who were participants in the Childhood Cancer Survivor Study. So they're 10 years, they're 10-year survivors, and they're now adults, and they answered questions in a male health questionnaire. Their mean age was about 37.8 years, and their years from diagnosis was a little more than 28. Overall, 36% reported perceptions of their own risk for infertility that were discordant, didn't match their treatment history. Let me show you what that looked like. So here, based on their cancer treatment, 857 got a treatment that would put them at risk for infertility. However, when you ask them, about 63% got it right. They said, I'm at risk for infertility, but 36% got it wrong. They said, I'm not at risk for infertility. And then the flip side, for those 376 who didn't get a gonadotoxic exposure, so they didn't get alkylators, heavy metals, radiation, about 65% said, I'm not at risk. I didn't get that kind of treatment. However, 35% here are incorrect. So they're worried about being infertile, maybe making life decisions based on that. And it's not even the correct information. So that was pretty disturbing. In this study by Irene Sue's group, it's a little different in that it's older females, 15 to 39, 785 females. They were 33 at the time of the study and had been 26 years from diagnosis. 61% perceived a higher risk for infertility they thought that they were at risk for infertility. They were more likely to report that they were at risk for infertility if they got high risk therapy compared to low risk therapy, odds ratio 15. Moderate risk versus low risk, odds ratio 2.7, or if they had irregular menses. And that makes sense with an odds ratio of 3, almost 4. However, the perceived infertility risk had minimal agreement with the objective data, and the case statistic here is 0.19. And lastly, this is a paper by Vicki Lehman from the St. Jude lifetime cohort study. So these are a little over 1,000 adult cancer survivors who don't have children and had never had a pregnancy. Their mean age was 29, 22 years from diagnosis. Their risk for infertility was dichotomized from a 5-point Likert scale. 62% perceived themselves to be at risk for infertility. Overall objective assessment of gonadal dysfunction was found in a little less than a quarter of females, a little more than half of males. Again, low concordance with the survivor's perception with the low K statistic. And this is another way of looking at it. And you see that in females, there is a 44% of them overestimated their risk, thought they were at risk and they weren't, whereas 5% underestimated their risk, thought they were not when they actually were. And then in males, overestimate 20, underestimate 16. All right, so they don't know whether they're at risk or not. Are they interested? And there's another interesting thing that Vicky's paper brings out, and that's, do you understand your level of risk based on your treatment? So we can do that from the COG protocols, blah, blah, blah. But actually, then they're actually getting tested. So they've actually had an assessment and they're still not aligned. So that speaks to, we need to communicate back to them. What does this mean and how do we look at it? So how many of them are actually interested in fertility status assessment? So the gold standard for fertility status assessment is semen analysis in males. There's some people that talk about doing FSH and inhibin, but it's really much less informative. And this was documented in the Dan Green paper in 2013. In females, it's a little harder because we're sort of trying to look at, again, these surrogate measures, but it's FSH and estradiol, and then AMH or AFC assessment for diminished ovarian reserve. And then to me, actually, the next step, it's so much easier in males. Just do a semen analysis. And I can tell you if you're making sperm. For females, you've got to look at their FSH and figure out their AMH, and then maybe go to an REI and figure out what does this actually look like. So this is a paper by Lena Nahata that looked at the interest in learning about fertility status assessment in male AYAs of childhood cancer, 45 males. They were about 19 years, 4 years since treatment. Most, a little over 2/3, reported they remembered being told of their risk for infertility at diagnosis. About 1/3 chose to cryopreserve sperm. And about 2/3 indicated, yeah, I'd like to know a little bit more about what my fertility status is now that I'm in survivorship. And this is a paper that Brooke Shervin, our mutual friend, and published from our site, looking at interest in fertility status assessment among young adult survivors. 259 survivors who came to Survivor Clinic and were engaged in a discussion with me or Megan about their risk for infertility. They were about 19 years, a little over half were male, and about 58% were non-Hispanic white. An interest in fertility status assessment was reported in a little over half of the males and 46% of females. And we defined that as a male said, yes, you can send an order for a semen analysis. Okay, that means you were interested. And in females, we've already talked to them about their FSH and their AMH. So a measure of interest was actually accepting a referral to an REI. So it's a little bit more of a step than just getting the hormone levels. Interest in fertility status assessment aligned with worry, was related to worry about infertility, which makes sense, right? In males and females, and having multiple discussions. Can't just say it once. Multiple discussions. And then in males, fertility consult at diagnosis, and and being at high risk. So I thought this was sort of interesting because this actually looks at their level of risk. And at that time we were using the low, moderate, high. And in males, their expressed interest increased from 38% to 63%. And in females, if they were high risk, up to 58%. But this really catches my eye. So this talks about, did you have one discussion about your risk for infertility in survivorship, or did you have more than one? And their level of interest goes from 39% to 72% in males and 33% to 62% in females. I think the first time you talk about it, they're like, well, I didn't see that coming. And then you come back and you talk about it. Now they've had time to process it and actually formulate questions and express an interest. Okay, so how are we going to improve risk communication? This has really become an interest of mine. So Brooke Shervin, again, who actually did, well, I keep looking at Wendy, she did her, she's our PhD nurse researcher who did her PhD here with Wendy and works in the field of fertility. And so she's been a great colleague. So we did this study to see how can we improve communication. And our aim was to evaluate effectiveness of an evidence-based educational intervention in increasing AYA survivors' knowledge of personal risk of infertility. Our methods. A priori, we decided on 4 key concepts, 4 things we want them to know when we get done, okay? Not 12, not a whole bunch of complex, 4 things we want them to know. We tailored the discussion based on their treatment and their lab, so it's a tailored discussion. We used a standardized educational protocol. We wrote out the script of what this conversation should look like. And then we did phase 1 and then modified our approach in phase 2. We used patient-centered techniques in teaching. We used PLICIT. So this has changed my practice. PLICIT is an acronym. The P in PLICIT is permission. I will say to a patient, would you like to have a discussion today about how your treatment could affect your fertility? I ask permission. It's game changing. LI is limited information. SS is specific suggestions. IT is intensive therapy, meaning if they break down and cry when I tell them this, we have a psychologist that will come back, clean up behind me. We utilize unhealthy teach